Let's talk about two hormones today. The first hormone that we're gonna talk is growth hormone, and the second one is prolactin. So both growth hormone and prolactin are twin hormones. It means their receptors and actions are quite similar. I remember them as baby needs growth hormone to grow, and it needs milk from his mom or her mom. Okay. So both of these hormones are released by anterior pituitary. So we have something called as pituitary gland. It's like this, and we have anterior pituitary, and then we have posterior pituitary. Posterior pituitary is called neurohypophysis, and anterior pituitary is called adenohypophysis. Adenophysis, not adenohypophysis. Okay, adenophysis is anterior pituitary, and neurophysis is posterior pituitary. Posterior pituitary, the posterior part, the back part of the pituitary gland, there is no synthesis of any hormone. It only works for storage, and the storage part is called herring body, and it stores two hormones, antidiuretic hormones called vasopressin and oxytocin. That's the hormone for your cervix to not cervix, the uterus to contract and move this fetus, right? So oxytocin and ADH. Okay, so ADH is released by supraoptic nucleus, SON, supraoptic nucleus, and oxytocin is released by paraventricular nucleus of hypothalamus. So note that hypothalamus is releasing both ADH and oxytocin. Okay, a hypothalamus is the master regulator of mostly all hormones, and so that's the thing, right? Hypothalamus gives uh, releasing hormones, and these releasing hormones, they go to anterior pituitary via which tract? Via hypophyseal tract. Hypophyseal tract. For example, this is hypothalamus, this is the stalk, this is the pituitary, this is anterior, this is posterior. So this tract is called hypophyseal tract, and this is how the hormones are released. So the classic story is the hypothalamus, it releases hormones, releasing hormones, then they affect on anterior pituitary, then the anterior pituitary releases trophic hormones. These trophic hormones, they go to the target or gland or organ, and then we have the effect, whatever the desired effect is, and then this target effect can give us effect, or it can give us peripheral hormones, and these peripheral hormones can give us the desired actions, and then we have a negative feedback loop for this secretion of hormones, because we don't want unlimited growth of these hormones, right? Okay, so let's talk about these two hormones called prolactin and growth hormone. So anterior pituitary has 2 cells and 6 hormones. 2 cells as in, first is acidophilic cells, and second is basophilic cells. So basic are blue color and acidophilic are pink color, and they are pink because the acid fast stain is like the acid removes all the it's the microbiological stand of point of view. And just remember that acidophilic are pink and basophilic are blue, because they love basic dyes, and basic dyes are blue in color. So acidophilic, we have two type of acidophilic cells. We have somatotrophs. Somatotrophs means they release GH. We have lactotrophs, means they release prolactin, right? So prolactin makes milk, and somatotrophs make GH, right? We'll only talk about prolactin and growth hormone. Okay, so what about basophilic? Well, basophilic cells, they love basic dyes, and they make 4 hormones. TSH, that is thyroid stimulating hormone. LH, that is luteinizing hormone. Follicle stimulating hormone, that's called FSH. Both LH and FSH are needed for fertility. Corticotrophs are endorphins, melanostimulating hormone, and ACTH, that is ACTH. So the thing is that corticotrophs, these all these hormones called endorphins, melanostimulating hormone, ACTH. All these hormones are coming from something called as pro-opiomelanocortin. Okay, pro-opiomelanocortin, POMC. And pro is like before, opio for endorphin, melano for melanocytes, and cortin for ACTH. Okay, so this is important, right? Cool. And by the way, TSH, let's talk about this TSH, LH, and FSH. Wait, let's talk about it. By the way, if you have a lot of ACTH, it leads to called Addison disease. In Addison disease, the ACTH is like hyper, and what happens is that this ACTH can mimic action of MSH. What is MSH? Melanocyte stimulating hormone, and you know melanocytes are responsible for giving you color of your skin, and because of same precursor they can mimic the action of MSH, and then we have hyperpigmentation. So let's talk about GH and prolactin. So hypothalamus has something called as releasing hormone and inhibiting hormone. So hypothalamus releasing hormone, it releases hormones, and then what this is the releasing hormone. So hypothalamus releases releasing hormone, and then it goes to anterior pituitary. Okay, so releasing hormone, there are four type of releasing hormone: TRH, CRH, GnRH, and GHRH. What is TRH? TRH is thyrotropin releasing hormone. It means it releases TSH, that is thyroid, right? Thyrotropin releasing hormone. Corticotropin releasing hormone, it releases ACTH. Gonadotropin releasing hormone, it releases LH and FSH, the fertility one. Growth hormone releasing hormone, it's for GH. Note that prolactin is released with the help of TRH. If you guys have low level of TRH, so low TRH equals to low prolactin. Okay, so TSH and prolactin go hand in hand. If a woman comes with low levels of TRH, she will have low TSH, thyroid stimulating hormone, and low prolactin. Okay, so we need to have good amount of TRH. Other thing, inhibiting hormones that hypothalamus releases. Why do we need to inhibit this? Because prolactin, we need good breaks on prolactin, because prolactin is not made a lot in quantity, so we need to release prolactin in good quantity, not in good quantity. We need to release prolactin in a very measured fashion. That's the thing. So we need breaks for prolactin, and those breaks are dopamine. And for GH, if you have a lot of GH, then you will have some sort of misformation, so we need breaks. So breaks of GH is called somatostatin. So somatostatin is released from growth hormone releasing inhibiting hormone, or called as somatostatin. Prolactin release inhibiting hormone called PIH, or called dopamine. Okay, so now you know that hypothalamus can make releasing hormone, it can make inhibiting hormone. Inhibiting hormone leads to prolactin being stopped and GH being stopped, and releasing hormone leads to TSH and prolactin increase, ACTH increase, LH increase, FSH increase, and LH-GH increase. So all go up, all go down. Okay, let's talk about growth hormone. So growth hormone is regulated by hypothalamus, of course. Hypothalamus gives positive response to somatotrophs. Somatotrophs make GH in anterior pituitary, and then growth hormone is secreted. Growth hormone has two work. One is direct, other one is indirect. Why growth hormone has to have two work? Why growth hormone has to have two action? Why direct? Why indirect? Why just not one direct? Well, because growth hormone is like a project manager, and growth hormone actually orders like raw material from your body. It like mobilizes, supplies energy to your body parts immediately. And it also manages IGF-1. I will tell you, it also manages construction crew for your body to build these structures using these raw materials. So growth hormones has two action. One is direct, the raw material, the glucose, everything raw, it's direct action. And indirect is using that raw material, using the when these raw materials can be used wisely, we can call it as indirect action. So indirect action is done by insulin like growth factor. It is insulin like, for it can mimic insulin. and somatomedin C also can mimic this insulin. And these both of these things, insulin like IGF-1 and somatomedin C, are made from liver. Okay, so if you have bad liver, so you will not make IGF-1, and IGF-1 is really important for growth of bones. Okay, so this is the story of this is the story of regulation of growth hormone. Again, growth hormone can be positively can be positively promoted, positive positively promoted by GHRH. This is GH, growth hormone releasing hormone, right? Here was growth hormone releasing hormone, positive, and it can be stopped by using growth hormone releasing inhibiting hormone, that's called somatostatin. So somatostatin, cool. So if you have problem in hypothalamus, you will not make this and this, and eventually you will have less, less levels of GH, and then less level of growth in your body, growth in your child. So we want good levels of hypothalamus. What about the diseases? Well, the disease is, one disease is pituitary dwarfism. Well, you can see if a guy is dwarf, it means there was less levels of, less levels of GH. So to treat, we need to give him GH. We need to increase the GH, and we can give GH analog as sermorelin, and this is the drug of choice for dwarfism. And for acromegaly, like you guys, if a guy already has a lot of GH in his body, we need to stop the GH, we need to inhibit the GH. We can give him somatostatin, and then stomatostatin, we can give him analog of stomatostatin called octreotide. Okay, so acromegaly, we need octreotide. Pituitary dwarfism, we need sermorelin. Okay. What about the factors? The factors that affect GH is, first is hypoglycemia. It means you have not eaten for a long day and your fasting blood sugar is very low. So this will lead to growth hormone release, and your blood glucose level will increase, because your body needs to maintain a good blood glucose level so that you don't die in a hypoglycemic coma. So that's why growth hormone is called diabetogenic hormone. So example, if you guys keep pushing GH inside your body externally, like exogenously, it will lead to you having diabetic mellitus. Okay, so try not to mess with growth hormone as steroids. And other part is stress can also release growth hormone, and this stress can also lead to diabetogenic hormone. And then we have something called as deep sleep. Children, they love to sleep, because they release a lot of growth hormone, and then this growth hormone leads to development, and this is done in NERM stage 3 and 4, the N3 levels. There are so N1, N2, and N3, and N3 is the third and fourth stage of NERM stage. Okay, it's non-random eye movement. Okay, so eyes are not moving. It means the guy is in deep sleep. Okay, it's really sleeping really deeply, and that's why I try not to wake children when they're sleeping, because their growth hormone is getting secreted. What about the downfall of growth hormone? How can we induce this? Well, we can feed him a lot. We can give him hyperglycemia. Just feed him a lot of carbs. Okay, growth hormone just shuts down. What about somatostatin? We can give him somatostatin, because somatostatin is an antagonist of growth hormone. What about IGF-1? Well, IGF-1 works in a negative feedback loop for hypothalamus, because all hormones in your body are controlled negatively, in a negative feedback loop. We don't want continuous flow of growth hormone in the body. So somatostatin antagonist. What about IGF-1? Negative feedback loop, again IGF-1. What about REM sleep? Well, the REM sleep is random eye movement, and if you have any REM sleep going on, so growth hormone will go down in REM sleep. So that was about the growth hormone. What about the action of growth hormone? Well, growth hormone acts via JAN-STAT pathway, and it acts on cytokine receptors. And then these cytokine, they just like insulin, they activate Janus kinase, and then Janus kinase further goes into pathways. A lot of pathways are there, so we should not, I don't want to talk about, because then the video will be really long. So growth hormone works via GenStat pathway. Note that prolactin also works via GenStat pathway. So this was GenStat pathway. What about the action? Well, there is direct action. The direct action is like mediated by GH, anti-insulin like actions, and indirect is insulin like actions. So direct action is lipolysis. If you don't eat a lot of time, then anti-insulin, so lipolysis. Bone growth, the number one function of GH is conversion of prechondrocytes into chondrocytes. Chondrocytes are the cells that secrete cartilage, and they make cartilage. They are cartilage forming cells, chondrocytes, and they are present at the epiphyseal plate. So if you have good levels of GH, there will be good levels of conversion of prechondrocytes into chondrocytes, and then you will have good levels of cartilage at your bone. If you have low levels of GH, then your bone formation, the cartilage formation, will be stopped. And by the way, indirect action is mediated by IGF-1. This IGF-1 is insulin. I'll tell you what the name. Insulin-like growth factor, IGF-1. Okay, so this is insulin-like, by the way. So if insulin-like, it means it is opposite of lipolysis. It will attract fat, right? So bone growth is also accompanied by IGF-1. And what happens is that all the remaining action after chondrocyte is proliferation and hypertrophy of these chondrocytes are done by IGF-1. So if you guys have really low levels of IGF-1, you will have something called as Laron dwarfism, which is basically less levels of IGF-1 in your serum, and you have something called as Laron dwarfism. Okay, what about disorders? Well, in children, you have something gigantism, again, a lot of GH, less GH, that is called dwarfism. Well, you have something called in adults, when already the most of the development is done after 22, after 23, you have, if you increase the GH by externally or internally by some adenocarcinoma, if you have some sort of adenoma, not adenocarcinoma. So if GH releasing pituitary because anterior pituitary, microadenoma. Okay, so you can remove this microadenoma using this surgery called transsphenoidal resection of microadenoma, okay, of anterior pituitary. Cool. By the way, so acromegaly. Okay, acromegaly. So acromegaly, the features of acromegaly. Number one, carpal tunnel syndrome. What is carpal tunnel syndrome? The nerves are compressed by the enlarged bones of this person. Okay. What about sleep apnea? The guy cannot sleep because the upper airway is obstructed by this enlarged things. Okay. Diabetes mellitus. I already told you that GH is diabetogenic, right? I told you that stress leads to GH, GH leads to blood glucose levels, and it's diabetogenic, right? So acromegaly, GH are high, so again a lot of diabetes can happen. Bony overgrowth called frontal bossing. Frontal bossing is that your face will look this is your eyes right here, this is your nose, this is your mouth. Here the bone structure will be enlarged because you have a lot of GH in your body. So frontal bossing happens. Hand and foot size increases. It's called prognathism, mandibular enlargement. This is your face, eyes, nose, mouth. Here the bone will be enlarged. Cool. Heel pad thickness, because soft tissue overgrowth will happen. So this usually can happen if you exogenously put a lot of GH, or you have some sort of microadenoma at your anterior pituitary. Okay, so try not to mess with GH. What about treatment of acromegaly? Well, treatment surgically, I already told you, transsphenoidal resection of microadenoma, and pharmacology, it can be octreotide and pegvisomant. That's a very weird name, pegvisomant and octreotide. So these are two drugs. So pegvisomant is a GH antagonist. It sits at this receptor and just doesn't let GH to bind with its cytokinase receptor. And octreotide is somatostatin analog. So I told you somatostatin analog is this one, octreotide. This one can be used for acromegaly, octreotide. Cool. Okay, so Larenz dwarfism, I already told you. If you guys have low levels of IGF-1, you will have Larenz dwarfism. And what happens is that it's just like type 2 diabetes, the GH insensitivity syndrome, lot of GH in the body, normal levels of GH or increased levels of GH, but the receptors are not working, so it's like having no growth hormone. So less levels of plasma levels of IGF-1 leads to this dwarfism and defective receptors. It can happen because if you like keep pushing a lot of GH externally, and then you have to give this person something called as micasirmin. What? Micasirmin. Okay, and it's a recombinant IGF-1. What does recombinant means? Recombinant is produced any drug that's produced using recombinant DNA technology, that is called recombinant IGF-1. Okay, what about other drugs? Well, recombinant drug of human growth hormone, this one, for muscle wasting in AIDS. You can give this drug for human growth hormone in AIDS because, because I'm not going to tell you because. And anti-aging, it's new, get jacked, it's just, it's normal information. It's nothing like new or nothing like wow. Okay, let's see about prolactin. Prolactin makes lactin makes blood, stimulates milk production, of course, regulation, high C. Hypothalamus activates lactotrophs in anterior pituitary, and then it makes prolactin, and then it makes milk, right? And how prolactin works is that prolactin actually increase the proliferation of lubulo-alveolar epithelial cells. These are epithelial, it means they are on the epithelium, and they are lubulo-alveolar, okay, on the breast. So this prolactin also works via JAK-STAT pathway, same as GH, and they act on cytokine receptor, activate Janus kinase, and then further pathways are there, right? So proliferation of lubulo-alveolar epithelial cells in the breast, right? Milk production is done. The negative regulator of reproduction. So if you have a lot of prolactin in your body, they work as negative regulator for reproductive health. That is, they inhibit GnRH. You know this by lactation amenorrhea. They inhibit GnRH. We know that GnRH, what is GnRH, huh? GnRH is gonadotropin releasing hormone. It releases LH and FSH. So if you put brake on LH and FSH, you won't be able to, make this endometrial layer. So LH and FSH, we need this for female reproductive health. So prolactin stops the endometrial layer being made. So negative regulator of GnRH inhibit FSH, lactation amenorrhea, loss of libido in men, loss of spermatogenesis in men, and this is the action of prolactin. And the hypothalamus makes lactotrophs, and lactotroph makes prolactin. Now this prolactin can be positively influenced by this thing called vasoactive intestinal peptide. It's called VIP. It's same as glucagon, and it's released during sucking, it's released during stress. It acts on as a co-signal just to make sure that lactotrophs is getting enough signal from TRH, thyrotrophin releasing hormone. If there is less signaling from TRH, the signaling from VIP, vasoactive intestinal peptide, will increase, and it can be negatively inhibited by, it can be inhibited, not negatively inhibited, it can be positively inhibited by prolactin inhibiting factor that's called dopamine. And we need this dopamine because I will tell you why. And it can be inhibited by glucocorticoid thyroid hormone that's called cortisol, and this can be inhibited by these things. And we need dopamine because because we need breaks on milk production, because milk is not unlimited. We don't have unlimited supply of milk, we have really less supply of milk. So we need a calculated, we don't want a lot of milk just going to waste. So we want to make sure that production of milk is calculated well. So we need good breaks. So that's why dopamine is there. So applied aspect, what's the applied stop effect? Well, if there is any lesion at the pituitary stalk or the pituitary stalk get destroyed. What is pituitary stalk? This is hypothalamus, this is the pituitary stalk, this is anterior pituitary, this is posterior pituitary. So if this stalk is getting destroyed, it means the dopamine which is made in hypothalamus cannot travel to the this anterior pituitary, and this prolactin is made in, in lactotroph of anterior pituitary. So there is no breaks if the lesion of anterior pituitary is there, right? Loss of releasing factor or inhibiting factor, loss of dopamine, so prolactin increases. You won't be able to, you will not have a lot of sex drive, lost sex drive, negative. You will have a lot of your GnRH will be inhibited for women, and so it really works like that. What are the factors like this? Factors of secretion. Well, the factors of secretion is, if you're pregnant, if you're lactating, you will have a lot of prolactin. If you're having sexual intercourse, if you're having a lot of orgasms, if you're sucking on nipples, if you are having REM sleep, the early morning sleep. So that's why pregnant women should sleep in early morning, because they need to have random eye movement sleep. They need to have that. And if they have this, what happens that all three of them, they work via decreasing the dopamine. And then if you have less dopamine, then you have high prolactin levels. And if you have high prolactin, then you will have, high proliferation of alveolar epithelial cells, and then you have milk production, right? What about the factors of less secretion of prolactin? Well, dopamine, of course, we know. L-dopa, of course, we know. The L-dopa is the analog. And bromocriptine is also an agonist of dopamine. Works via D2 receptors, okay? So this was prolactin and GH.